Good evening, dear colleagues. This is the second of the start of a webinar, a national webinar, brainchild of Dr. Satish Parasar, whose indefatigable efforts have kept the Indian Academy of Echocardiography at its very zenith. Continuing medical education is an important tool that helps healthcare professionals stay current with the latest scientific advances in the field. As such, the Indian Academy of Echocardiography is furthering academic activity. Thereby, it has chosen multimodality imaging as an integral part of echo studies. In a large number of cases, multimodality imaging plays a key role in diagnosis and prognosis. Majority of the cardiologists and many echocardiographers also are not very conversant with cardiac CT and MRI, and so possibly bypass or ignore the relevant presentations. With this in mind, Dr. Parashar crafted the series of webinars so that all these lacunae can be overcome. I will now introduce Dr. Nitin J. Burkule, who actually is one of the leaders in this field, both in echo and in cardiac imaging, and requires no introduction at all. But nevertheless, as a formality, let me tell you that he is a person who's been trained in the Schneider Children's Hospital in pediatric and intra-op echocardiography after his post-graduation in JJ Group of Hospitals way back in 1996. He is a fellow of both the American College of Cardiology and the American Society of Echocardiography. He is a past president of the Indian Academy of Echocardiography and is currently the director, Department of Cardiology at Jupiter Hospital, Thane. His greatest thing has been his leadership role in the field of echocardiography, both within the academy and also in the spread of knowledge. And towards this, he has co-authored a number of publications, which include ASC guidelines of ASD and PFO and stretch echocardiography in coronary artery disease. He has also been a guide in comprehensive adult transthoracic echo and transesophageal echo and TE in cardioembolic stroke. The podium is yours, Dr. Nitin. Kindly take over.
Thank you, Dr. Raghu, for that kind introduction. I will quickly go through the credits for these city lectures. We are going to have it on every first Wednesday of every month, and we have already finished part 1 of cardiac CT on 2nd July, and it is available on the YouTube. And I would advise those who are interested in cardiac CT to go through each part in series so that there will be a continuity. These academic and non-commercial city lectures contain a lot of figures, slides, videos, and information from various books, journal articles, open access websites, YouTube sources, so and so forth. So delegates are requested to go through these original sources if they want to go in depth. And these are the different sources from which I have received some of the figures and some of the videos apart from my own contribution. So I will, and this particular credits and acknowledge it for all the 4 parts of city lectures. Now I will move to this particular lecture on cardiac CT, and I will share my screen. So dear friends, now let us look at the cardiac CT different scanning techniques. The first scanning technique is called as axial sequential scanning. So what does this method do? What happens is that you have one rotation of the gantry to create one slice of data. Then the table moves, and then you get the second slice of data. Again, the table moves, and you get the third slice of data. So that is how you cover the entire heart from base to apex. Now, this sequential axial sequential scanning is also called as step and shoot. So after you shoot a particular slice, the table moves exactly the thickness of that slice so that you get a contiguous sections for every step and shoot. So this particular technique is useful for the city coronary angio, and it also saves a lot of radiation, but also it has got a lot of downside also, because if you are not catching the second set of volumes exactly in the same phase of the cardiac motion, you can have step artifacts. So how much data do you need to create one cross section of the CT image? Actually, the projections which are in the opposite direction are actually telling you the same story, the same attenuation story. So that means you really don't need the gantry to go all the 360 degrees around the patient's chest to get one slice of image. You can get the same image by just rotating through 180 degrees. So that means it is only the half rotation of the gantry that you get entire data for creating one CT slice. So suppose if your gantry is moving around the patient in 300 milliseconds, then in 150 milliseconds, you can create one volume of data set of the heart. So how do you utilize that for the CT coronary angiography? As we know that the coronaries would be continuously moving with the cardiac cycle, we need to shoot them when they have got a relatively least motion. And that period of least motion is generally at 70% of the RR interval in the late diastole before the atrial systole. So it is important that you have got a narrow window of imaging during which you can take one slice of data sets to have the least coronary motion and to get a very diagnostic coronary angiogram. So most of the imagers use 70% of the RR interval and choose a window, the width of which is around 10% of the RR interval. So that means if you have got a heart rate of 60, you have got an RR interval of around 1000 milliseconds. So 10% of that, that means you have got a 100 millisecond window in late diastole, which is at 70% of the RR interval. That means somewhere around 700 milliseconds. You have got a 100 millisecond window to catch the coronaries with the least motion artifacts. So how can you prolong this imaging window? Now, as we know that as the heart rate drops, as is shown on the x-axis, the duration of the systole, which is shown by blue dots, and the diastole, as shown by the red dots, the duration of the phase goes on increasing, and it is much more remarkable in the diastolic timing interval. So as the heart rate drops to 60, you have got anywhere around 650 milliseconds of the phase duration in diastole. So it is very likely that you would be able to get a motion-free window of 100 or 150 milliseconds during which you can have the snapshot of the coronaries for that particular volume of data. So that is the importance of having the low heart rate during CT coronary angiogram, because as we know that we have only 10% of RR interval where you will have least motion artifacts. So that is 100 milliseconds for a 60 heart rate. While if the heart rate is 40, it will be 150 milliseconds. It will be very good. But of course, it is not practical to have that kind of a heart rate. And as we had seen that to get a good data set of the cross section, we need half gantry rotation, which is around 150 milliseconds for most of the modern scanners. So 60 is an approximation where you would get less motion-free coronary imaging. So lower the heart rate, better it is. So the thing is, the ECG gating is very important in the CT scanner because you want to catch this motion-free window period. Now, in the second best motion-free window period, though small, is at end systole. Okay, so in some patients, especially for the right coronary or when the heart rates are slightly higher, you may get a better motion artifact-free coronary imagings in late systole also. So what happens in a cardiac CT sequential axial scanning? You are targeting this particular 10% RR interval image window in the late diastole at around 70% of the RR interval. So you have one gantry, half gantry rotation in this particular period to get the cross section or the cross sectional volume of the heart. The next RR interval is used for the motion of the table. So it's called the table feed. So in the third RR interval, you would take the second volume section of the heart at this particular 70% of the RR interval. Then again for the next RR interval, there will be a table movement. And then in the next RR interval, you will take the third volume data set. So generally for a 64 slice CT, as we know that this one half a gantry rotation will cover around 4 centimeters of the heart volume. So if you stitch them together, you are covering around 12 centimeters of the heart volume, which generally covers or suffices for the origin and to the apical portion of your coronaries. Now remember that you have to catch the next volume of the data set exactly at the same phase of cardiac cycle. Otherwise, you will get step artifacts. So it's very good theoretically that the axial sequential scanning will have an economy of radiation because you are turning the radiation on only during this period of imaging. But the flip side is that if you miss this phase, then you have absolutely no data in the other part of the cardiac phase. So this is how you are doing in a 64 slice CT. You are using 7 heartbeats, of which 3 heartbeats are utilized for the table movement from one slab to second slab. And in the first slab, you take in the first RR interval. In the third RR interval, you take the second slab of data. In the fifth RR interval, you take the third slab of data from the heart. So the temporal resolution is nothing but how fast you can acquire the snapshot of the heart. So suppose if you have a very wide imaging window, there is a chance that the coronary may move during that period and may produce a whiplash like an artifact. However, if your imaging window is small, then there's a possibility that you will have a motion artifact free coronary lumen seen in the image. However, as we know that physiologically also there can be a little bit of RR variability, and especially when the patient is holding breath. So what does the machines do is that they turn the radiation on not only for the imaging window period, which is suppose 100 milliseconds, but also few milliseconds before that and few milliseconds after that. And it is called as padding. So that means you start acquiring data not strictly in half the gantry rotation, but a sector before that and a sector after that. So you are not strictly into 180 degrees, but you would be something like say 240 degrees of rotation. So that you have some padding data before and after the imaging window period, so that even if there is some change in the RR interval, still you have the same phase data acquired in your CT image. Then the next way is to do an helical scan, okay, or it is also called as the spiral CT scan. So what does that mean? Here, the gantry and the cone beam of the X-rays is continuously moving, and the table is also continuously moving. So you are acquiring a data in a spiral or helical fashion. So you have a continuous rotation of the gantry and a continuous feed of the table, and you scan the entire heart from base to apex and get a helical data set instead of step and shoot. Now, obviously, here the radiation is on throughout, isn't it? So that means obviously this is not, there is no economy of radiation here. So each of this spiral ring will create one image, and there will be a stack of images from base to apex with this kind of a helical or spiral scanning. The now this is how the spiral is created. Now this particular thickness of this helix is nothing but the row of detectors. So more the row of detectors you have, thicker would be this spiral arm. Now, suppose if the table is moving, the same distance as the thickness of this spiral or this detector length, then what would happen is that you will have all these detector paths very close and adjacent to each other. While if the table moves faster, then this detector path will all get spread out, and you have got areas in between, or the volumes of the heart in between, where you have no data. Now, suppose the table moves very slow. In that case, these spiral detector pathways will overlap each other, and there will be oversampling. So this particular movement of the table vis-a-vis with the gantry rotation is measured by the pitch. So what is pitch? Pitch is the table movement per rotation, per gantry rotation, divided by the X-ray beam width or the detector width. So suppose the table moves per rotation exactly equal to say W, then you will have each of these spirals close together, and then the pitch will be 1. Now suppose the pitch is less than 1, that means the table is moving slowly, so that you will have all these detector pathway overlapping each other, and you will have good oversampling. So most of the cardiac CT is done with the pitch values of 0.25 to 0.3. So there is a lot of overlap for the same volume of the heart. When the pitch is more than 2, that means the table is moving faster. So that now these spirals of the detector pathway spread out. So in between there is a gap of data, and so that means you will not have all the phases acquired for these volume of the heart, which is lying in between the two adjacent spiral pathways. So this is how it has been shown. So pitch 1, you have got all the spirals stacked together one after the other. Pitch 2, you have got a gap in between. And pitch 0.5 is that all these spirals are overlapping each other. Now, so here is the mathematics. Here you have got a table travel 80 millimeter per gantry rotation, while you have got a 64 scanner where the detector the path is 40 millimeter wide. So that means you have got a pitch 2. When you have got the table movement of 40 millimeters for every gantry rotation, and your beam width is also 40 millimeters because you have got 64 slice CT, your pitch is 1, and you have got all closely stacked spiral pathways. While pitch 0.5, because table is traveling at 20 millimeter per rotation of the gantry, and the beam width is 64. So all these spiral pathways are overlapping almost 50% over each other, and you are oversampling the some of the volume data sets of the heart, where you are taking all the phases of cardiac cycle. Then when the pitch is high and you have got certain chinks in the data sets, those are filled up by a mathematical interpolation. So the helical data set that you get, you retrospectively get it to the ECG data, and then look at this particular end diastolic imaging window where you want to pick up the coronaries when they are not moving. So that this is called as the retrospective gating. It is as opposed to that step and shoot that we saw, which where it was prospective gating. So retrospective gating is quite safe because you have got the all the phase data with you, of the cardiac phase data with you for the entire volume of the heart, and then you go back, assign it to the ECG cardiac cycles, and then pick up the window as shown by these blue stripes, from which you construct your coronary angio. You construct your coronary angio data set. Now, interestingly, that if there is some RR variability, physiological variability, you really don't have to fret because you will have data. So suppose even if the RR interval has slightly changed and the phase has moved, you still have captured that data with you. So the chances that you can construct the coronary CT images much better. At the same time, if you are not getting very satisfactory images in the late diastole, you can always look at the end systole for creating the coronary angiogram for say a right coronary artery, so that you can you get relatively motion free images because everything is there with you. But however, as you are seeing that the radiation was on throughout, so you are irradiating the patient a lot more. So how do you get around it? The best thing that you can get around it is that you know that you are going to use the data only of the end diastole, and you are going to waste that entire data of the remaining phases of cardiac cycle. So then why do you want very high quality data which you are going to throw away? So why not have a very milliampere X-rays only during late diastole, and in the rest of the cardiac cycle, you have a very low or modulated current so that you irradiate the patient least. So in that case, you have got a little lower quality of data in the rest of the cardiac cycle. So that is how you can modulate the radiation and reduce the radiation dose. Now let us look a little more conceptually at this spiral data set that you are acquiring. Now this spiral data set, if I want to unwind and spread it, then it will spread out in the space and time like this. So this particular detector pathway which winds around the heart, if I spread it out on the X and Y axis, where X is the time both for the cardiac phases and the time of scanning, and on the Y, the volume of the heart, or the distance on the heart that you are covering by the table feed, then this particular spiral data will get spread out in the diagonal direction. So this is the leading edge of your detectors, this is the trailing edge of the detectors. And then you can look that for every level of volume, you have actually acquired all the cardiac phases in the cardiac cycle. Now, suppose if you have got a very slow pitch like this, in that case, what is happening is that you are actually having oversampling, which may be good also, but at the cost of high radiation. That you can see that this particular volume of the heart, you have got actually the cardiac phases data from 3 cardiac cycles, okay, which is like your oversampling. However, if you are having, and that is how you, since you are having all the cardiac phases with you, you can create the synchronicity images. So, though these synchronicity images look like the echo or the cardiac MRI images, their frame rate is very poor. Rather, their frame rate is the least as compared to the echocardiography or cardiac MRI. Now, suppose if you have got a very fast pitch like this, and then if you look at the cardiac volumes, then you will realize that these are the spaces in between, of this particular cardiac volume where you do not have the data for the entire cardiac cycle. Okay, so for this particular volume, I'm not going to have the entire cardiac cycle data set. However, if I just look at the end diastole, then even for this amount of cardiac volume, I have got the entire data set at the end diastole. And not only that, for the next volume and for the next volume, I actually have an overlap. Okay. So that is how interesting that though I am having a fast pitch, I'm able to capture the end diastolic imaging window for coronaries for the entire volume data set of the heart with a certain degree of overlap too. And that is how you can create a much better city coronary static images in the late diastole. However, if you have got a very fast pitch, in that case, obviously you have got a very large areas. Now, even at the end diastole, as shown by these red bars, where the cardiac volume does not have any image data set from this end diastole, and you have got this gap of volume data at end diastole. So you will lose this particular volume of the coronary. So, as we discussed that to economize on your radiation in a helical scan, you don't keep the X-rays at the same intensity throughout all the cardiac cycle during your spiral scanning, but you modulate the current in such a way that it is only in the end diastole that you have got a higher current and higher X-rays, and rest of the time you can turn them to very low or even to zero. So this is how you try to conserve the radiation and try to capture the high quality images when they are really required for the coronaries, while rest of the cardiac phases you have got low radiation and low quality of images, which may be good enough to get a cine cardiac CT, but not for obviously coronaries, but they may be good enough to get your cardiac volumes at end diastole and systole. However, that synchronicity data that you get is has got a very low frame rate. So summary of the techniques, we have got 2 techniques. One is that called as prospective gating, which is a step and shoot. That means you have got one gantry rotation, then the table moves, then you have got second slice by one gantry rotation, then again the table moves. And as you know that it has got the least radiation, but the problem is that you do not have any other cardiac phases. If you have missed that particular cardiac phase and your and your study may become non-diagnostic, while you have got a retrospective gating where you use a low pitch helical scanning. Problem is that you give a high dose of radiation, you try to modulate it by having the X-rays at a very high milliampere only in the end diastole, and then you go backwards and then look at the all the phases and get the best phase where you get the motion free coronary images. And 6 to 4 slice CT is the one which is most optimal for that technique. Now let us look at the ways the spatial and the contrast and temporal. Hello. This was the end of the lecture about the techniques, and I think we can go ahead with the next part of our program.
Thank you, Dr. Nitin. We'll take questions in the last 20 minutes of this webinar. Am I audible?
Yes, sir.
Yeah. So we'll move on to the.
Yeah.
Hello.
Yes, sir.
Yeah.
You
Please go ahead. Yeah.
Yes. Very good evening to all of my viewers, respected Parasar sir. We have already completed first part of the regarding the CT scan and heart. But the second, our talk, today's talk is very important. And generally, most of our clinician, echocardiologists, we are not very much giving a much detailed idea on particularly for the pulmonary vein Dopplers. So today's pulmonary vein Doppler in the diseases is very, very important topic we are going to discuss. And our speaker is Dr. Shraddha Ranjan. She is a senior consultant cardiologist from the Patna Medanta Hospital. She has a keen interested in all part of the non-invasive heart failure as well as coronaries, and she is doing a lot of good work in echocardiography. Today's talk is regarding the pulmonary vein Doppler. As we all know that there are a lot of clinical condition whether the pulmonary vein Doppler will be the clue for the clinician, particularly the diastolic failure, left atrial failure, all the conditions related to the left leading to left atrial failure, pulmonary hypertension, whether there is a very significant clue for that. Generally, as a practical screening cardiology, we are neglecting this topic, but this is a very well, and the next 20 minutes will give us a very good ignite on the Doppler of the pulmonary vein. So Dr. Shraddha, podium is yours, and I hope everybody will enjoy.
Thank you, sir, for the very kind introduction. As good evening to everyone, and regards to the senior members of Indian Academy of Echocardiography. Before starting, I would like to thank Dr. Parashar sir and Dr. Manish Bansal sir, Simi ma'am, for giving me this opportunity and also helping with the subject matter. So as sir rightly said, that pulmonary vein Doppler, we know that this is a very integral part of any comprehensive echocardiographic study. However, not many of us do it in the routine practice. Is my slide moving?
No, not yet.
Not yet. You're on the title page only. Okay. Maybe you can unshare and share again, please. Yeah, you came to the main deck. Yes, this is fine.
Yeah,
So I'll start. So as I was saying that not many of us are doing it routinely. And though it will not be helpful every time in all the cases, but yes, it is little tricky to image. So if we are doing it in routine practice, As and when required, if there is a case, we can get very valuable information from pulmonary vein Doppler. So the idea today will be, I'll be dividing my talk into 3 parts. First, we'll be getting familiar with pulmonary vein imaging and Doppler assessment. In the second part, I'll be dealing with the normal pulmonary vein flow physiology, how it looks, what it means, what are the waves. And then at the end, we'll see some various disease states where assessment of pulmonary vein Doppler is helpful. So we know that the pulmonary veins are thin-walled, highly compliant conduits which drain into the left atrium. And this acts as a reservoir which maintains the LV stroke volume during beat-to-beat variation, the respiratory variations. Doppler waves in the pulmonary vein mirror the pressure waveforms of the left atrium, and they mirror what we call as JVP. We can see it because pulmonary vein flow comes into the left atrium. We can mirror, the hemodynamic understanding of LA filling can be seen through the pulmonary vein Doppler throughout the cardiac cycle, and it also reflects the LV filling during diastole when the mitral valve is open. As I said, it is little tricky to image because the pulmonary veins are posterior structures. They are very far from the probe on the transthoracic study. The codes may be sometimes variable. Apical views on transthoracic echoes are best for visualization and also alignment with the pulse wave Doppler. While doing transesophageal echo, they are better visualized, yet it needs some expertise in identifying each of the pulmonary vein one by one. So this is the normal 4-chamber view, apical 4-chamber view, which is LA. We have to get a left atrial and pulmonary vein focused view, which means that the depth has to be there so that we can see the pulmonary veins. This is the right pulmonary vein, and this is the left pulmonary vein. And these are the transthoracic views, which one by one we'll see. The upper two show us the right pulmonary veins, right-sided pulmonary veins. So I'll take a moment here to tell about the relations, because if we understand the relation that right-sided pulmonary veins will be closer to the interatrial septum and the right atrium for that matter, and superior vena cava. So whatever the image is there, whatever views we are dealing with, whether we are doing a transthoracic or transesophageal echocardiography, this will always hold true that right-sided pulmonary veins will be near to the interatrial septum and superior vena cava. As we can see here in the top 2 images, this is the interatrial septum with a little anterior angulation. We can see right upper pulmonary vein, and at the same, if we angulate the probe little posteriorly, we can see the right lower pulmonary vein. The same holds true for the left-sided veins. In the left-sided vein will always be adjacent to the left atrial appendage and anterior to the descending thoracic aorta. So if we remember this relation, it will be easier to identify the veins. In transthoracic, left upper pulmonary vein is very close to the left atrial appendage, and the left lower pulmonary vein is little difficult to see, but it can be seen in the modified parasternal short axis view. This is a supraesternal crab view usually used in pediatric cases where the supraesternal with the anticlockwise angulation, we can see the left atrium with all the 4 pulmonary veins. This is taken in a young adult, and these are the left pulmonary veins, upper and lower, and these are the right. Coming on to the transesophageal views for pulmonary veins, as I said that we have to remember the relation. Near to the left atrial appendage will be the left veins, and right veins will be near to the superior vena cava. So we can see that in many different views, pulmonary veins will be visible many times during a transesophageal study. However, if you want to see simultaneous, these are 2 focused views where we can see both the left-sided veins in one view. This is a mid-esophageal view, where at an angle of around 90 to 110 degrees, if we do a extreme leftward rotation, we can see both the veins in an inverted V kind of pattern draining into the left atrium. And these are the right pulmonary veins, which if we start from 0 degree near the interatrial septum, we can localize right superior pulmonary vein. And if we angulate to around 30 to 50 degrees with her extreme rightward deviation, we can see both the right upper and lower pulmonary veins simultaneously draining into the left atrium. So coming on to how to take, so this is about the imaging. So now that we have imaged pulmonary vein, Next step is to take the Doppler waveforms there. So first we have to ensure optimal ECG tracing and optimize the 2D image quality. If the flow is not well visualized, we have to reduce the velocity scale because it's a low velocity flow. The sample volume location should be 0.5 to 2 centimeter inside the pulmonary vein to avoid the artifact of the LA wall. The color sector has to be narrow to maximize frame rate and ensure alignment of the Doppler signal with the flow. The speed has to be adjusted and to be kept similar during the whole study because we have to compare the pulmonary vein and transmitral flow for further information. This brings me to the next part of my presentation. We'll discuss the normal pulmonary venous flow. So as we can see here on the right side of the screen, this is how it correlates. This is the cardiac. This is the cardiac cycle. This is we can see as the systole starts, we can see it's a triphasic flow. Triphasic, and most of the flow is antegrade because the blood is coming from pulmonary vein into the LA, so most of the flow is antegrade. As the systole starts at the end of the QRS, the systolic wave of the pulmonary waveform can be seen. It can be divided in S1, S2, but for now we will just take it as S wave. It corresponds with the X descent. Then at the end of the T wave, when diastole starts, there is a diastolic wave. This diastolic wave corresponds to the E wave of the transmitral waveform, and after diastolic ends, after the P wave, there is a small atrial contraction. There is a atrial wave which corresponds with the A wave on the transmitral flow. Here also on the left side now you will see that this is a pulmonary vein waveform, normal pulmonary vein waveform taken in a person. So this is a S wave. So how S wave is formed? This is flow from as the atrial contraction ends. After the P wave, as the atrial contraction ends, there is the atria is relaxing. So pulmonary vein will flow the drain into the relaxed LA. And simultaneously, after the ventricular systole starts, there will be an RV ejection. Right ventricle will contract and eject the flow into the pulmonary circulation, which will push the blood from the pulmonary circulation into the pulmonary veins into the LA. At the same time, left ventricle is also contracting. There is some apical displacement of the mitral annulus, freeing up the space, making some space in the left atrium. So that will also cause systolic wave antegrade flow into the left atrium. So this corresponds with the LA reservoir phase, X descent, and it depends on the compliance of the left atrium. If the atria is contracting well and relaxing well, S wave will be normal. Then this is the diastolic wave. This is also an antegrade flow as I talked about it. It happens when the mitral valve opens. The blood will come from LA to LV and so from pulmonary vein into LA. It is a conduit phase, corresponds with the LA conduit phase, Y descent, and the E wave on the transmitral flow. It reflects the LV relaxation and compliance because at this time the mitral valve is open and LA, LV are in a sequence. Then there's atrial A wave, which is also called as atrial reversal because it is a retrograde flow. This is a brief retrograde flow because now the atria is contracting, mitral valve is closed. So there will be some obvious backflow inside the pulmonary veins. So this is retrograde. And if it is prolonged or if it is the velocity is more, this predicts a high LV filling pressures. So this was the normal pulmonary venous flow, but we should not haste in labeling it normal because there is some age effect, age dependency here. So we have to take care of that. As in this, we can see that the S1, S2 can be two independent waves, or it can be fused. Both are normal. But in very young adults, in juvenile children, the S wave will be blunted. We will see eventually that a blunting of S wave denotes some pathology. However, if the LV is very compliant, it is relaxing very well, then the diastolic wave will be more prominent than the systolic wave, but it is not abnormal. So coming on to the third part of my presentation, pulmonary venous flow in disease. So this is from the latest guideline of diastolic function, LV diastolic function from American Society of Echocardiography. Will not go into detail, but here we can see that these are the three primary indicators of the echocardiographic indices for the LV diastolic function. If the E prime velocity is reduced less than 6.5, E by E prime is more than 14, or TR velocity is more than 2.8. If all three are normal, we know that it is normal left atrial pressure. If all three are abnormal, we know that we are dealing with increased left atrial pressure. However, when it comes in between, any two or any one or two variables are abnormal, here comes the role of pulmonary vein flow patterns. So as we can see, S by D ratio of less than 0.67, if it is there, it will indicate that it will push our diagnosis towards increased left atrial pressures. So this is the importance where these are the cases where this becomes really important. So we'll see some examples. So this is grade 1 diastolic dysfunction. I'll just put it there. Here we can see that this is grade 1 by mitral valve, mitral flow pattern. We can see it is grade 1. In the pulmonary vein flow, we can see this S is bigger than D. S by D ratio is more than 1. And A duration velocity, the A velocity duration is also normal. It is equal to the mitral valve A velocity, and the A velocity is also not high. So this suggests that this is normal filling pressures, normal left atrial pressure. However, then we come on to the indices which shows us that there is a LV diastolic dysfunction is present. So if we get a reduced S velocity, S by D ratio is less than 1, and systolic filling fraction, which is systolic VTI upon total forward flow VTI, which basically means that there is lesser amount of antegrade flow during systole, it is less than 40%, it indicates that there is an increased left atrial pressures. But this holds true usually only with the patients with reduced ejection fraction, heart failure with reduced ejection fraction. The second indices are what we talked about, the A velocity. If the pulmonary vein A duration is more than the mitral valve A duration, transmitral A duration by 30 milliseconds, AR velocity is more than 35, it indicates an increased LVDP. So why does this happen? Because if the LV and diastolic pressure is more, then it will cause premature equalization with the LA pressures, and the mitral valve will close, causing the mitral A duration to be very sharp, very less. And there will be pronounced backflow because still the LA pressures are not low. So that is the concept behind it. And this indices, it does not changes with the ejection fraction. It holds true for even for the normal ejection fraction and HCM and mitral regurgitation. So this is we'll see a case of reduced ejection fraction. It's not moving. So this is I have put it's not moving. The 4-chamber view of a reduced LVEF. This is ischemic cardiomyopathy with significant mitral regurgitation. Here there is a grade 2 diastolic dysfunction. We can see that E by A ratio is 1.7. Mitral valve A duration is 129. And when we take a pulmonary vein flow pattern here, so S wave is less than the D wave. This is S wave. S wave is 43.43 meter per second. D wave is 0.89. So S is smaller than D. There is a definite blunting. Then we have to see the pulmonary vein A velocity and duration. The velocity is 46. It is more than 35. And the duration is 217. So there is more than 217 minus 129. So it's around 80 to 90 milliseconds more than the transmitral A duration. So which completely takes us to the diagnosis of increased LA pressures and increased LV filling pressures. But this sometimes cannot be true. So suppose in the case of a hypertrophic cardiomyopathy, again we are dealing with a grade 2 diastolic dysfunction, but when we see the pulmonary venous profile, we do not see a blunting of S wave. S wave is more than the D wave here. However, the AR duration we can see here as the two blue lines, we can see that this is the pulmonary vein A duration, which is significantly more than the mitral valve A duration. Coming on to the diagnosis of high LV and diastolic pressure. Then coming to the mitral regurgitation, as we understand hypothetically, theoretically, it should be like that the mitral regurgitation is coming from left ventricle to left atrium to the pulmonary vein. So there should be as the severity of mitral regurgitation increases, there should be blunting of S wave. And eventually there should be a reversal of S wave. The reversal of S wave is seen where the blood will go back into the pulmonary vein from the left atrium. But this is not so straightforward. This all will depend upon, as we can see, the first is S is more than D. So this is a normal profile. This should hold for mild MR, but it's not so. It can be seen in mild MR, it can be seen in moderate, it can be seen in severe, as it is written here. This happens because it will depend on the chronicity of MR. It will depend upon the compliance of the LA. If the LA is compliant enough, we will not see blunting of S wave. And if the MR is chronic, the same will hold true. So that we have to understand before considering this. But if the we can see that there is a reversal of S wave, then we have showed that it is a severe MR. So reversal of S wave is very specific. However, it's not so sensitive. In this example, we can see that there is a eccentric significant MR, anteriorly directed jet, and there is a late systolic reversal. This is the S wave. There's a late systolic reversal in the pulmonary veins. This is the D wave. So S reversal, mid to late or holosystolic reversal will be seen depending on all the factors which I just discussed. This has become very important in the TEER procedures, mitral clip procedures, where in the transesophageal echo. So this is the pre-procedural echo, where mitral clip is being planned. And there is a significant S reversal here, which you can see. This is the S reverse, and this is the D wave. After the procedure, we can see that there is no retrograde, no reversal of the flow, just antegrade flow here, and the small atrial reversal wave are noted. These are the more important, what we have discussed are the more important pathologies. Then in ASD, there is a
last
single
minute talk, please.
Okay, sir. I'll just find out. So there's a single waveform because there is uncoupling of the pulmonary vein to LA. If the LA pressures are high, the blood will pass into the right atrium. So the phasic flow will be is lost, and there is a single forward waveform. Constrictive pericarditis, we can see respiratory variation also in the pulmonary vein, and we can use it to distinguish it from the restrictive cardiomyopathies. Atrial fibrillation and flutter, there are no discernible S or D waves, just a small atrial waves can be seen. And this also has shown a prognostic value where the difference between the pulmonary vein A and mitral valve A duration has significantly shown towards a trend towards a higher cardiac mortality and hospitalization. And also if S is less than D, there is a higher rate of heart failure, hospitalization, and death. These studies have been done in reduced ejection fraction. I have taken most of the talk this is a very wonderful article shared to me by Dr. Parashar sir. So for further reading, we can always go back to this article. Thank you.
Thank you, Dr. Shraddha. That was a really lovely talk. I felt as if I was learning pulmonary vein Doppler.
Dr. Raghu, you are muted. Please unmute yourself.
Yeah, I don't. Are you able to hear me now?
Yes, sir.
Yeah,
So thank you for the lovely talk. I felt as if I'm relearning the pulmonary vein Doppler, very lucidly presented. We'll move on to the next talk. Dr. Jha again will introduce the next speaker.
again, very good evening to all of my seniors and my friends and or my viewers. The very interesting cases, although by the speaker, Dr. V. Vatslasri, she is a very good cardiologist from the Velo, and without other, I request her to start the interesting case report for that.
Good evening to all, and thanks to all the senior members of IAE for this privileged opportunity, and my specific thanks to Dr. Parashar for his ongoing support. Today, I'm going to present a case about a 23-year-old female who came to my OPD for a routine echocardiogram evaluation prior to her job in Chennai. As a child, she was told to have a hole in the heart, which according to the parents, they were reassured that the hole will close as she ages. They, however, didn't have any prior documentation about the reports. On direct questioning, she admitted shortness of breath NYHA class 2 to 3, which she thought was normal. However, she denied any history of LOC. There was a very remote history of palpitation, occasional history of palpitation. Apart from that, the past medical history was insignificant and she's not on any regular medications. On examination, her vitals were stable and there was a harsh systolic murmur that was here all over the precordium. Her biochemistry was normal. So the echocardiogram showed, the parasternal view showed a left ventricle, which I thought was mildly hypertrophied. There was some malalignment or overriding of aorta, and I was able to see a small discrete structure that was protruding into the left ventricular outflow tract. The aortic valve itself, the right coronary cusp and the non-coronary cusp were clearly seen. And there is a very, very small dent there, appearing as if she may have a small perimembranous VSD, which she was told as a child. Again, in this static image, we are able to very clearly see the overriding of aorta and a very small fibrous structure protruding into the left ventricular outflow tract, along with the cusp, the coronary cusp, the cusp of the aortic valve, and a very small opening there, suggesting a perimembranous VSD. The color flow confirms a turbulent flow across the left ventricular outflow tract, aortic regurgitation, and a shunt left to right, suggesting a perimembranous VSD. The peak systolic gradient of this shunt, which I thought was a perimembranous VSD, is 80 millimeters of mercury. The short axis view confirmed that she had a tricuspid aortic valve, which, however, I wanted to confirm it later through a transesophageal echo, which I could not perform. The four-chamber view again shows the mitral and the tricuspid apparatus to be normal, very mild left ventricular hypertrophy, and a normal left ventricular function. Here, I'm able to see a discrete membrane, and there is also some suggestion that there can possibly be another fibromuscular structure here, which raising a question whether this is a case of a discrete aortic membrane causing aortic left ventricular outflow gradient, or whether this is a fibromuscular ridge. Color flow again shows turbulence across the LVOT along with AR and a left to right shunt. In the three-chamber view, it is much clearer, the fibromuscular structure, and I'm not able to see any structure here. So I thought this is a discrete discrete membrane, supravalvular membrane. So there was a moderate aortic stenosis with a peak LVOT gradient of 66 millimeters of mercury and a mild to moderate aortic regurgitation. Again, the LVOT gradient peak was about 65 millimeters of mercury with a mean gradient of 37 millimeters of mercury. The aortic arch or the ascending aorta, which the major side input was not dilated, and there was no coarctation of aorta, or there is no significant holodiastolic reversal flow, suggesting a significant AR. This is just to show that the mitral apparatus was normal and there is nothing to suggest that she had a SAM. The LV systolic function and the LV diastolic function was normal, although the E by E prime was 14, which may suggest that she's starting to have some early diastolic dysfunction. The global longitudinal strain was normal at -20 with an ejection fraction of 57. So subvalvular aortic stenosis, also called subaortic stenosis, is a rare disorder seen in infants and grown-up adults if untreated. It involves the presence of a membrane that is typically muscular just below the aortic valve, which causes a fixed obstruction to blood flow across the LVOT. SARS may co-occur with other congenital heart disease, including VSD, PDA, COA, bicuspid aortic valve, abnormal left ventricular papillary muscle, and or ASD. Although rare in occurrence, SARS is the second most common type of aortic stenosis in newborn. It is responsible for approximately 1% of all congenital heart disease and 15 to 20% of all fixed LVOT obstruction. 10 to 14% of SARS is observed amongst children with congenital aortic stenosis. It is more common in male with a male to female ratio of 2:1. It contributes to 6.5% of all adult congenital heart disease. And the VSD, the PDA, pulmonary stenosis, aortic coarctation, and other lesions can be coexistent. There are some variants of SARS that includes accessory or anomalous mitral valve tissue, as we can see here, or a discrete aortic membrane which is present in our patient eye thick. This discrete membrane can be single membrane or it can be two membrane. It can also form a fibromuscular ridge and a elongated and a diffuse fibromuscular tunnel-like narrowing of the left ventricular outflow tract. The usefulness of 2D echo helps us to assess the extent and involvement of LVOT, the integrity of aortic valve and mitral valve, definition and location of the subaortic valve stenosis, the degree of left ventricular hypertrophy, post-stenotic aortic dilatation, filling characteristics, associated congenital heart disease, the function of left ventricle. A transesophageal echo or a 3D echo may be indicated if inadequate, I'm sorry about this, if inadequate information or adequate information could not be gleaned through 2D echo. AR in subaortic valvular stenosis. AR may develop during the course of the disease. Encroachment of the fibroblastic tissue and the trauma due to high stenotic jet traumatizes the aortic valve and causes AR. This may also cause post-stenotic dilatation of the ascending aorta. 65% of patients develop AR, which is progressive and persistent even after SARS is surgically removed. AR is usually mild. However, the severity may rise with an increasing pressure gradient. Due to AR, the left ventricle, which is already pressure overloaded, becomes volume overloaded, further increasing the left ventricular oxygen demand. Indication for intervention: if the mean gradient is less than 30 millimeters of mercury, nil intervention and only medical follow-up is advised. If the mean gradient of the LVOT is between 30 to 50 millimeters of mercury, and if the patient is symptomatic, intervention can be considered. If the mean gradient is more than 50 millimeters of mercury, and even if the patient is asymptomatic, the patient may need some kind of intervention. Surgery as such is not indicated to prevent aortic regurgitation. However, if the aortic regurgitation is progressive or severe or is causing symptoms, then surgical intervention can be considered. Other general consideration includes treatment options. The treatment option includes surgically resecting the membrane. Sometimes an aortic valve replacement or aortic valve repair can be done, and a balloon dilatation of the LVOT can also be considered. IE prophylaxis is recommended only if there is a prior history of infective endocarditis. Subvalvular aortic stenosis as such does not qualify for IE prophylaxis. The differential diagnosis includes hypertrophic obstructive cardiomyopathy, supravalvular aortic stenosis, bicuspid aortic valve causing stenosis, and valvular aortic stenosis. So to conclude, subaortic valve stenosis, although rare, is a common cause of congenital aortic stenosis. It can occur in isolation or in association with other congenital heart disease. It is a progressive disease. 2D echo plays a key role in establishing the diagnosis and to assess suitability of treatment and further follow-up. Symptomatic patient with a mean LVOT gradient of 30 millimeters of mercury and asymptomatic patient with an LVOT gradient greater than 50 millimeters of mercury warrant treatment. IE prophylaxis is not a routine. Thank you so much.
Thank you, Dr. Vatsala.
Sir.
Can we take up questions? I am unable to see the questions from my screen. Dr. Dai, if you could.
Yeah, please.
Questions are in the chat box, sir. You can open the chat and you can see them.
Actually,
Yes,
before we go to the chat box regarding Vatsala, we had two cases who were referred from somewhere else as cases of Hocum. But they turned out to be subaortic stenosis with a massive LVH. So that nowadays, whenever we get a patient of a suspected Hocum, we always look for a subaortic membrane. And they usually have what is known as a pseudosam. Because of a hypercontractility of the LV, the pseudosam occurs in late systole. Although she has mentioned that is always a very important aspect to be seen in all cases. Now, any questions? Actually, I had put
very
two
good.
questions.
Very interesting. Sir,
Yeah.
very interesting, Dr. Vatsala. We are getting sporadically few cases in yearly of these SARS cases. Very interesting one. Our middle-aged woman I have got with the 90 plus LVOT gradient and emergency operation. Most probably I'll put this case in Eco India. I'll show that part. But let us now begin the question chat box, and I will start with Dr. Parasar's questions. Is CT coronary angiography more important or coronary calcification? This is the
Actually,
basically common, yeah,
my
query is
question,
that, sir,
Nitin, was
regarding the
that what is the range of heart rate which is acceptable? Because whenever you ask for an appointment for a CT angio, they don't tell you anything.
yeah,
Okay,
yeah,
so
yes.
what is the acceptable range, 60 to 70 or 60 to 80? And secondly, now they say that coronary calcium is more important not to see the coronary artery blockage. So these are two, three things for Nitin.
Yeah. Uh, yeah, exactly. This is a very practical question. Now the 64 slice, generally the 64 slice CT is a workhorse in most of the city coronary centers. So there, I think you should have the heart rate around 60 and no atrial fibrillation, no RR variability. And it is better that you start their beta blockers and ivabradine at least 48 hours before, so that they have a very good heart rate when they go for it. Now the thing is, the centers, much advanced centers where you have got a very wide detector set like 320 slice. Uh, Probably, yeah, it's in one gantry rotation, they can cover the entire cardiac volume. Okay, these are very expensive scanners, and very rare, very few centers are having them. And then you also have dual source cities where, which we'll discuss later on. The dual source city also, the scanning can be done very fast, and many places, and there probably the heart rate or the heart rate variability may not be that important. But I think most of the centers in that we will be having around will be 64 slice city, and the heart rate control is very important. Second question is about the calcium score and the coronary angio. I think these are two different aspects. Calcium score, I think, is for the screening for an early atherosclerosis. Okay, so generally, many times your ASCVD risk score, like in primary prevention, when your ASCVD score is very low, and you patient has got a strong family history of coronary artery disease, and you just want to see the early atherosclerosis, then city coronary calcium scores come handy, especially when to take the decision about the statin initiation of statin therapy. And especially if the city coronary calcium score is high, then almost you can start something like a secondary prevention kind of treatment if this calcium score is like 300, 500, 600 range. Secondly, if your city coronary calcium score is very, very high, then probably your assessment for the luminal narrowing can be very poor. So if you have got a very high city coronary calcium score, better not to go for a city coronary angio, because then you will get a lot of blooming artifacts because of the calcium, and your assessment of the city coronary angio can be wrong. Now comes the question is whether you would like to look at the obstructive disease, and what about city calcium score 0? Now, city calcium score 0 puts you at a very, very low risk of the coronary events, but that doesn't rule out an obstructive disease, because only 1 in 6 plaques may have calcification. So what you are picking up is an extent of atherosclerosis by coronary calcium score, but you are not actually looking at the obstructive coronary disease. Now, in these, now where you would use the city coronary calcium, city coronary angiogram, I think it's a very big debate. But roughly speaking, probably since city coronary angiogram has got a very high negative predictive value, I think patients with a low pretest probability and symptoms suggestive of angina, I think they are the best one to get sorted out by the city coronary angio. But I would never use it for the patients who have got multiple comorbidities, have very high pretest probability of having coronary artery disease. In these patients, to evaluate the atypical anginal symptoms or even the anginal symptoms, I would use the functional testing and not go for anatomical testing. But that's a very big debate question.
Very,
I have two
very
comments.
nice, sir.
I have
Yeah,
two comments, Dr. Jha. One is to Dr. Vatsala. In your images, the subaortic ridge was not complete. There was no complete membrane. However, the gradient was very high. In such situations, a 3D echocardiography often shows is better adapted to show the complete membrane for causing the severe aortic stenosis. Generally, partial membranes do not produce such severe aortic stenosis. And I probably would have used the three-dimensional echo to show that the membrane is complete, possibly circular, with a passage with a rent in it, producing severe aortic stenosis.
Yes,
My
sir.
second comment or question is to Dr. Shraddha. How would you assess, use the pulmonary vein to assess diastolic dysfunction in the presence of atrial fibrillation?
Yes, sir. In atrial fibrillation, again, it will be quite difficult, but we can use blunting of S wave may be there. We can, but atrial reversal and A duration we cannot see.
Yeah. So regarding Dr. Paras's questions regarding the CT scan and Nitin sir, particularly we are using 128 slice CT scan, most modern for our CT angio particularly. So we are following the rule of 50s, particularly if ideal 51 to 59, 60, it is the best to get a slice. But what happened practicality? Last 140 patients, we have just presented a case. Most of the time, in spite of the beta blockers, sometimes it gone to up to 80s, we are accepting the 80, 82 is well. But above 90, we never accept the patient. We again prepared it, and now we are sometime even IV beta blockers is planning to give the itna. Most of them we are giving metoprolol regularly 4 hours, 6 hours before that in pre-night also. And regarding the negative value, as it has a more negative value, particularly predictive value, and the sensitivity 93%, whether specificity is only 81% of that. So intermediate, as rightly you said, low to intermediate risk factor of the Framingham risk, we are putting the patient for the this coronary CT. And one more question regarding the CSC versus coronary angio. In our center, we used to do together at the same time CSC as well as the coronary angio together, and starting the Egerton score regarding to we are planning for the future strategy for the coronary angiogram of that. But the some center and majority of center as if only using CSC as a only as rightly said that particularly for the risk stratification, and just if it is a very high we are going for the directly coronary angiogram for that. So CT scan particularly for the together as a CSC is also one tools for important tools for that I think. And nowadays it is a in regarding case preparation is equally important, because out of 100, 5 to 6 patients, whether the heart rate become 96, 106, whole cycle report have gone. The physiology team, we are planning always, and just we have produced one series of the 130 patients of the CT angio. And on that basis, heart rate is very, very important for the whole reporting and quality of the construction of the 3D image of that.
Dr. Raghu, can we have a concluding remark now?
Yes, sir. Thank you to all the speakers. It was a wonderful session. Dr. Nitin, it was really wonderful to hear the basics and make oneself aware of the methods of doing the CT of the CT scanning of the heart. That was really a very lovely talk, and I'm sure will be very helpful to all the youngsters who have attended the program. Dr. Shraddha very nicely demonstrated all the methods of obtaining pulmonary vein Doppler and the various changes in the pulmonary vein Doppler in health and disease. And finally, we had Dr. Vatsala giving us a very interesting case of subaortic stenosis. This was really a wonderful evening. Till we meet again, thank you and good night.
Thank you.
Thank you.
Night.
Thank you, sir. Good night to all. Yeah.
Thank you.